Yeah, sounds good. Yep.
All right, can you guys hear me? Great, well, welcome. Thank you all for spending part of your weekend with us to learn about sleep, and thank you to the World Sleep Society for inviting us to take part in this great event. Today we'll be talking about women and sleep, and we'll be looking at sleep disorders specifically in pregnancy and after menopause. My name is Melissa Lipford. I'm a neurologist and sleep doctor at Mayo Clinic in Rochester, Minnesota, and a woman, which might pertain to this talk as well. I have no disclosures today. We'll start by talking about obstructive sleep apnea. What is it? Why should we care about it? The last talk, we already talked a little bit about it. We'll specifically focus on the impact on women during pregnancy and after menopause, and then we'll talk about advances in treating sleep apnea in women. We'll then discuss restless leg syndrome, and we'll close with a discussion about insomnia. Each of these topics are going to get their own attention as you move through the course of the day, but here I wanted to highlight a few issues that pertain specifically to women. So what is obstructive sleep apnea? We talked a little bit about it in the last talk as well, and I'll give it my take as well. Obstructive sleep apnea is not a lung disease like emphysema or COPD. It's an upper airway disorder. And if we think of the upper airway, it's the distance between our nose and the trachea, or that hard part of the airway. If you think of that airway as a tube, you breathe in air through the nose and mouth, and that air has to go through that tube before it gets into our lungs. Well, the inner lining of that tube has all these soft tissues and muscles, and they're just fine when we're awake. But as we sleep at night, just like our body relaxes, all of those soft tissues drape inward, and they reduce how much room there is for air to pass through. And so as you're breathing in air through the nose and mouth, as those structures get really close together, they start to vibrate, and that's all that snoring is. And sleep apnea is simply when those structures collapse together and block the airway. You're trying to breathe, but that air can't get into the lungs. Well, the brain has such a robust need for oxygen. It's constantly monitoring our oxygenation status, our airflow, and if we're not drawing enough air in, within about 10-20 seconds, the brain realizes it and it wakes us up. With that wake up, those tissues tighten up and the airways open, we breathe beautifully, but then we drift back to sleep and those tissues relax again and obstruct the airway. So obstructive sleep apnea is repetitive episodes of those airway soft tissues collapsing and obstructing the airway, and the brain waking us up from sleep. And it's those wake-ups that actually drive those cardiovascular risks associated with sleep apnea. Even though we don't remember these wake-ups, we just don't register them into our memory bank, but each one is associated with a surge in our heart rate and a surge in our blood pressure. And so night after night, year after year, these changes strain the cardiovascular system. It increases our risk of high blood pressure, irregular heartbeat like atrial fibrillation, stroke, and heart attacks. There's other health risks associated with sleep apnea too. It worsens acid reflux, it can worsen our blood sugars, it can lead to depression, it affects our memory, and chronically disrupted sleep makes us tired. That impacts our judgment, our reaction time, and can lead to increased risk of automobile accidents. Specifically, looking at women, obstructive sleep apnea is present in 2 to 5% of all women, so it's about half as common as it is in men. But if we look at certain subsets of women, the prevalence becomes far higher. So women that are at a higher body weight, women that are pregnant, and women that are postmenopausal are much greater risk. And the reason I wanted to focus on sleep apnea for this talk is because 90% of women are undiagnosed. And part of that is because women often lack those classic sleep apnea symptoms that occur in men. Like we talked about in the last talk, that loud freight train snoring, that typically arises in men. Our airways simply don't always generate that volume of snoring. And men are typically very sleepy. Women, we're tired, we're fatigued, we have low energy. Often those wake-ups driven by sleep apnea, we wake up and we can't get back to sleep. So women report insomnia. And sleep apnea really has an impact on our mood. It reduces our energy, our drive, we have lower motivation, we're irritable, and so that lends doctors to go down the pathway of depression, wherein it all could have been due to sleep apnea. Sleep apnea is also increased risk in pregnancy, and during pregnancy, women go through so many physiologic changes. Some of those actually protect our airway and respiratory status, but far more of those changes actually topple the balance over to increasing risks of sleep apnea in women who are pregnant. In pregnant women that have sleep apnea, they're at increased risk of gestational diabetes, high blood pressure, they have higher rates of unplanned C-sections, and babies of women that have sleep apnea tend to be smaller. So evaluation for pregnant women for sleep apnea is recommended in those that have symptoms suggesting sleep apnea, those who are already at higher risk of complications, and those who are at an increased body weight, particularly as they get into the third trimester. The risks of sleep apnea also skyrocket after menopause. We think sleep apnea is present in up to 20 to 56% of postmenopausal women. That is a ton of people, and again, it is markedly unrecognized. Part of this is because of the reductions in estrogen and progesterone as we approach the menopausal years. Estrogen and progesterone have an impact in terms of tightening the upper airway structures, and they support our normal respiratory drive. As those hormones start to level off, the airway, just like other things in our body, tend to become more floppy and more prone to collapse. Also, as women approach the midlife years, we tend to put on extra weight. That also increases our risk of having sleep apnea. And there's some emerging evidence looking at relationships between hot flashes and sleep apnea. 80% of midlife women complain of hot flashes, and it definitely disrupts sleep. We did an interesting study at Mayo Clinic looking at women with hot flashes, and the more severe their hot flashes were, the higher their risk of having sleep apnea was. So we need to do some more work to figure out these relationships better, but here again is a symptom that is only there in women and might get missed and interpreted as something other than sleep apnea. And so if there's concern for sleep apnea, what is the next step? Well, first, report problems with sleep, or if you're not feeling rested during the day, to your doctor. Often these are not questions that are asked about during a routine physical, so you have to mention them. And the testing for sleep apnea has evolved over time. We still do in-lab polysomnography studies where there's more monitoring equipment. You spend the night in the sleep lab, but there are also home-based tests. These are more efficient, more accessible, and you can just wear a little device and sleep in the comfort of your own bed. And so for a woman who's healthy, and the question is purely, do I have sleep apnea or not, these home-based testing approaches might be a bit easier. And finally, how do we treat sleep apnea in women? Well, CPAP therapy still is the gold standard in treating sleep apnea, and it involves a little device you keep at your bedside, and it delivers air, not oxygen, just room air, and it's the flow of that air that keeps those airway tissues open, preventing the collapse. But just like we talked about in the last session, comfort is a major issue affecting people using and adhering to CPAP. Well, fortunately, the device manufacturers, especially over the last few years, have put a lot of research and development into making these devices more comfortable. They now back off on the pressure as you exhale. They can automatically shift the pressure so you're not getting more than you need. We humidify that air so it alleviates the problem with dry mouth or stuffy nose. And the interfaces have come a long, long way. Finally, the people that make CPAP devices have sorted out that women have sleep apnea too, and so they've devised interfaces that are smaller, they're soft and squishy, and they really are low profile and better fit a woman's facial structure. And certainly there's still people where CPAP is just not a realistic option. And for those folks, there are lots of alternatives. Like we talked about in the last lecture, there are oral appliances or mandibular advancement devices. These are devices that are custom made by a dentist, and they can be a very elegant solution in treating sleep apnea in those who have mild or moderate disease. You pop these in your mouth before you go to bed at night, and that's all it is. If you travel, it's just this little thing you toss in a bag. It couldn't be easier. There's positional therapies for people that only have sleep apnea when they sleep on the back, and there are newer surgical approaches like hypoglossal nerve stimulation. Those are indicated for people that have more significant sleep apnea but cannot tolerate CPAP. And why should we do all the legwork to sort out sleep apnea and treat it? Because treatment is associated with significant benefits. People, when they have their sleep apnea treated, they have far better sleep quality, they wake up feeling refreshed, and they have energy throughout their day. There's also a reduced risk of cardiovascular events like strokes and heart attacks, and most people find an improvement in their mood as well. So it's really a win-win. And this is an intervention. It's not like a drug that has side effects. This is something that really doesn't harm you in any way. And then I thought I'd throw this one in there too, the concept of beauty sleep. Our colleague, Dr. Shervin, he did a neat study where he took people that had sleep apnea and he took a picture of them. And then he let them be on treatment for a few weeks and had them come back and he took another picture. And then he had people off the street rate which image was more attractive. And most people chose the image on the right. So for whatever it's worth, treating sleep apnea may make you look better too. So now we'll talk a bit about restless leg syndrome. What is it? This is a disease that has a circadian pattern. The symptoms typically only happen in the evening and nighttime hours. It's not typically a painful disease, but it's uncomfortable. People that have this, when they're resting in the evening, like they're trying to watch a little TV before bed, or they're laying in their beds trying to fall asleep, they get this intense urge to move the legs. It is like the heebie-jeebies in your legs. You literally cannot stay still. If someone paid you good money, you couldn't stay resting. You must move. And movement is the only thing that alleviates your symptoms. Typically, people have to get up out of bed and pace the floor. When they come back to rest, those symptoms may come right back. It affects 14% of women, so it's far more common in women than in men. It worsens during pregnancy and after menopause. People that are at increased risk of having restless leg syndrome are those that have a family member that have it, those who are iron deficient, and those who have certain medical conditions like kidney disease or nerve disease. And restless leg syndrome has a spectrum. Some people have symptoms once every couple of months. They walk around or jiggle their legs a little bit and it's gone. But then there's the other side of the disease. There are people that struggle with this night after night. Their body's exhausted. All they want to do is lay in bed and fall asleep, but they can't. They're compelled to move. They're up all night pacing the floor. In those folks, this is associated with a significant reduction in quality of life. It's associated with terrible insomnia. And there's some newer literature showing that restless leg syndrome is also associated with increased risk of cardiovascular events. So what do you do if you think you might have this? You've got to bring it up to your doctor. This is another one of those diseases that's not commonly asked about, but it affects 2 to 7% of the population, extremely common. One of the first things your doctor will do is check your iron levels. If your iron levels are low, they might start you on an iron supplement. That can go a long way with helping with symptoms. There's also behavioral interventions, things that you can do to alleviate and prevent symptoms. Those are things like sticking to a daily exercise regimen, stretching the legs before bed, massaging the legs, taking a warm soak before bed, and then there's these mechanical devices that use counterstimulation or compression or massage. Those can go a long way to help symptoms. And if those aren't working, there are great prescription medication options that are safe and can really turn things around for these patients. So we'll talk next about insomnia in women. It affects 1 in 4 women. Some women have trouble falling asleep. We call that initiation insomnia. Some women have trouble staying asleep. We call that maintenance insomnia. And some women are lucky enough to have both. I think everyone sitting in this room at one time or another has experienced insomnia. Maybe they're under stress or whatever. But there's a lot of people that have this night after night, year after year. And it can really ebb away at quality of life. And I think this is one of the least recognized health burdens that affect people. Chronic insomnia lends to mood problems. It can increase our risk of heart disease. It increases our risk of developing memory problems, both short-term and down the line. And if we're not sleeping well, it affects our metabolic rate. It can lead to obesity. Also, if our sleep is disrupted, that next day, it's much harder to make really good choices about what we eat. Sometimes when we're up in the middle of the night, you don't go for the carrot stick, you go for the bowl of ice cream. And it makes it harder to adhere to a good physical exercise regimen, so it certainly contributes to obesity. Insomnia in pregnant women is extremely common. Up to about 80% of pregnant women experience insomnia, and it's for a lot of different reasons. There's many hormonal alterations that disrupt the sleep. There's just physical discomfort. The baby's movements can wake us up. Acid reflux and nausea. I don't know why they call it morning sickness, because it absolutely happens at night. And then there's the psychological impact of pregnancy. There's excitement about becoming a new mom or adding to your family. There's also a lot of stress associated with it. And it's those emotions, both good and bad, that can really disrupt the sleep. Pregnant women usually have to get up once or twice in the middle of the night to make a bathroom visit. It can be harder to get back to sleep after that. At least 15% of pregnant women have restless leg syndrome. And like we talked about, a lot of pregnant women have obstructive sleep apnea. In general, the sleep tends to worsen through pregnancy, becoming the worst during the third trimester and shortly after delivery. So how can you sleep better during pregnancy? Keeping a regular sleep schedule is key, allowing your body 8 hours of rest nightly, avoiding daytime and evening caffeine, getting an exercise regimen in, and there's special pregnancy pillows that support the belly and support the back and help to alleviate some of the discomfort. If you must take a nap, make it a short one. 10 to 15 minutes is actually optimally refreshing, and it won't take away from your next night of sleep. There's some great relaxation techniques you can use before bed, and that gets to those psychological impacts of pregnancy, and certainly to be evaluated for other diseases that can wake you up from sleep, like obstructive sleep apnea and restless leg syndrome. Insomnia is also extremely common after menopause. We think at least 50% of midlife women experience insomnia. It's probably more than that. It's probably just that not that many women actually complain about it. It is due to lots of different factors. Hot flashes, like we talked about, other sleep disorders, sleep apnea, restless leg syndrome, and then finally stress. I see a lot of midlife women in my practice, and it's a consistent theme of stress. Women in this period of life are going through balancing family and career demands. They may be trying to figure out ways to care for aging parents. They're going through empty nest syndrome. Some are struggling in their marriage. And there is nothing like a dark, quiet bedroom and a woman's brain to just think through all of the problems in the world. Even though your body is exhausted, you cannot get to sleep because of that active mind. And so how do we treat this? Well, one of the first things is to sort out, is there another sleep disorder? Is there sleep apnea? Is there restless leg syndrome? There's other sleep disorders too. These are things that can wake you up and then make it hard to get back to sleep. So treating these helps to consolidate the sleep. In terms of treating the actual insomnia itself, cognitive behavioral therapy approaches have come about in the last 5 years or so, and this really appears to be the best way of treating chronic insomnia. It's about retraining the brain, behavioral exercises that teach the brain how to deliver efficient and consolidated sleep. This is something that's going to stick with you, whereas the medications are the historical way we used to treat insomnia really is not a sustained model. It's important to treat mood disorders separately. Depression and anxiety, mood and sleep go hand in hand. If the mood is poor, the sleep will be poor. These disorders really require independent attention, and often then the sleep follows suit. There are over-the-counter agents like melatonin that can be helpful, especially in the short term, but make sure you talk to your doctor before starting any new medication, even the over-the-counter ones, because there are certain people that shouldn't take melatonin. And then in select individuals, there still is a role for prescription sleep aids, and there are newer agents that might be safer for long-term use and have less long-term side effects. If the insomnia is due to hot flashes, there are great treatments for hot flashes. There are behavioral measures like sleeping with by drinking a cool beverage before bed, sleeping with a fan pointing at your face, avoiding caffeine or nicotine. There are great relaxation exercises that just sort of help you get back to sleep after a hot flash. And then there are lots of medication options which really reduce the number of hot flashes. And there are now both hormonal and non-hormonal based options. So definitely talk to your doctor about what approach might be right for you. And so just to close, a few take-home points. I want you to remember that sleep problems are extremely common in women, especially during pregnancy and after menopause, but they are treatable. It's so important to talk to your doctor about sleep problems and get them sorted out and get you on treatment, because treating the sleep, getting the sleep to be deeper, more restorative, is typically associated with improvements in quality of life and your overall health. Obstructive sleep apnea is often missed in women because we don't have the same symptoms that men do. It's often overlooked or diagnosed as being something else. And just to remember that the testing approaches have evolved and treatment strategies have become far more comfortable for women. And then lastly, consider evaluation and treatment for restless leg syndrome and insomnia. These are two diseases that you're going to have to bring up to your doctor. These are not things that come up during a routine physical. And it's so important to bring them up because there are great modalities in treatment that employ behavioral options as well as good medications that are safe. And with that, I'll end, and I'll be happy to take any questions. Thank you.
Hello, my name's Jim. I'm an anesthesiologist, and my wife's going to the meetings downstairs.
Oh, great.
So I'm showing up for this.
Welcome.
Great question that I have regarding this. It's twofold. It's more of a opinion than a question. One is recognizing the issues of sleep apnea in pregnant women and postpartum, and also recognizing the issues with postpartum depression that was recently highlighted on some, I think, Good Morning America or Today Show.
Sure.
How much effort has been made to reach out to the OB folks or OB community to recognize this rather than just, you're fine, you're 33 weeks, okay, great.
Right.
Because I think that's where the ball gets dropped in some of that stuff there.
I think you're absolutely right. And I think pregnancy is often looked at, oh, this is short term. Even if you have sleep apnea now, it's going to go away. But we need to really spread the word to our OB colleagues that, yes, even though pregnancy is short term, first of all, many of these women who have sleep apnea still will have it after pregnancy. And there are risks to both the mother and the fetus by having untreated sleep apnea during pregnancy. So at our institution, we do a lot of grand rounds, and we invite our OB colleagues to join in some of our lectures trying to educate. We try to bring this up at national meetings like this one. We usually try to have little sleep sections even at anesthesiology meetings, some of the OB meetings. So we're certainly trying to get the word out there. But it also, part of these public forums is also just increasing public awareness so that if you are pregnant, you know someone that's pregnant, mention it to them that should I bring this issue up with my doctor? So great question. Thank you. Yep.
Hi.
Just one second. Sorry, one person first. Yeah, sorry, go ahead, sir.
Yeah, is it proper to ask, what if sleep is disturbed by a need for bathroom visits, one or two? Is it proper to ask that here?
Absolutely. So the question is, what if sleep is disrupted by bathroom visits? So great question. And it's really interesting because, yes, especially in men, as we get a bit older, there's a reason from prostate hypertrophy to maybe need to go to the bathroom during the night, but we've definitely linked sleep apnea and excessive bathroom visits. There's a lot of physiologic reasons why you might have increased urine output at night if you have sleep apnea, but also sleep apnea wakes you up. And what do we do when we wake up? Well, we go to the bathroom because we're trying not to wake up later in the night. So it certainly could be linked to a sleep disorder. It's one of those soft signs that we think about in terms of sleep apnea. So excellent question. Go ahead.
Thank you. I was wondering, what is it, you can be really tired and almost falling asleep, and on the verge of falling asleep, wake up and you're just absolutely wide awake.
Yeah, I think that's the female brain. I think sometimes men have a switch here, like on the lights, that they can just kind of turn it off. So there's a lot of reasons that why we wake up and might not be able to get back to sleep. First of all, wake-ups are normal. Our bodies are hardwired to wake up periodically during the night. It's back from the caveman days. We had to wake up and assess our surroundings and make sure we were safe and a saber-toothed tiger or whatever isn't going to eat us. So we all wake up during sleep. But the normal response is to reposition, know that we're safe, and get right back to sleep. But there's that active mind piece. Often, if we're up long enough and we can't hold on to that kernel of drowsiness and get right back to sleep, the mind likes to engage. Even though we can be physically exhausted, the mind can be active. And that's really where those cognitive behavioral therapy approaches can be really robust, because they target that active mind, they teach you how to disengage the brain, get back that drowsiness, and fall asleep. And they teach you how to do it on a consistent basis.
What I actually meant was I'm just falling asleep, ready to fall asleep, and I can't get over that edge of falling asleep. All of a sudden, I'm wide awake.
Wide awake.
Like I haven't fallen asleep yet.
Yeah. So it could be some different things. One, there's something called sleep start. Sometimes you feel like a little movement. Sometimes you even have a little jerking movement. That's called a sleep start. It's normal, just as our body's kind of letting go in between being awake and being asleep. But there's some good relaxation techniques that just can kind of help you get back to sleep. But I think, too, when that you're almost there and then you just wake up, part of sleep that makes it difficult is it's the ultimate act of letting go. You are literally going from being conscious and fully in control of your body to being very vulnerable and unconscious. And again, I think that's where sometimes these cognitive behavioral techniques sort of set the stage and kind of walk you through that process of sleep, so it doesn't have some of those associations.
Where would you find these techniques?
So the best step is to talk to your doctor, because usually they're done under the direction of either a physician or a sleep psychologist, but there are some online tools that are available now as well. Some are really hokey. You have to be careful about what you get online. You want something that's evidence-based, but definitely talk to your doctor. This is a strategy that we're seeing has robust benefits in the long term, and it can't hurt you. So great question.
Hello. I have a question regarding melatonin. Which type of people can't use melatonin?
Oh, good question. So melatonin is generally a safe over-the-counter agent. Sometimes we use it in children. We use it throughout adults. And while it's not the most robust agent, it can help with falling asleep. It has kind of a mild sedating effect. And in general, it has very low risk of side effects. But certain people shouldn't take it, particularly those that are on blood thinners. So warfarin or Coumadin interacts with warfarin and can change your blood clotting values. And so there are a few specific examples where it would be good to talk to your doctor, and certainly in the pediatric population, not to start any of those drugs before talking to your doctor.
And is melatonin safe in pregnancy?
It's generally considered safe in pregnancy, but again, it would be one where you'd want to talk to your doctor, have the doctor look at all of the other medicines that person was on.
And in terms of that lady that had the question, I'm an integrative family physician. And one trick that I use with my patients is ask them to connect their thumb and their index finger, and you keep your other finger straight. And within 5 to 10 minutes, you'll fall off to sleep. This is called Gyan Mudra. It comes from India. So mudra is spelled M-U-D-R-A, and there's multiple mudras for different conditions and different situations using only your fingers and your hands.
Excellent. Well, thank you for sharing that. Appreciate it. All right, I'm being told my time is up. Thank you all for your attention and great questions. Much appreciated.